Okay, I think we'll make a start now. So, hi everyone, I'm Namo Bidu. For those who've just joined, I'm the membership manager at Cambridge University Hospitals. Thank you so much for joining us this evening. The lecture will focus on Cambridge IVF, which is tackling infertility with advanced technology and research. So, without further ado, I'll hand over to Chris White, our staff governor and also host for this evening. Chris, over to you. Thank you.
Thanks very much indeed, everybody, for attending. So I'm Dr. Chris White, and I'm the IVF Director in addition to being a staff governor. So what we're going to be doing this evening is taking you through some of the key elements of reproductive medicine. So Dr. Alka Prakash is our lead clinician, and she'll be talking to you about the incidence of fertility issues, but also what she does, along with her colleagues, the other consultants, what they do in terms of individualising care to try and make it as effective as possible. So that's what Alka's going to be covering. Then we're going to go on to Michelle and particularly talking about ultrasonography and what we use that for and the advances. Now, I've got to say, of the whole presentation, I like it all, but my favourite bits, I've got to say, are the nursing, when you can see how much the technology has changed. Then we're going to be going on to male fertility and the issues there. And I think you'll be absolutely staggered by the incidence of male fertility. And that's going to be Elisa. And Elisa is our lead in andrology or male fertility. Yeah. So if I didn't say, I'm not sure if I did. Michelle actually is our nurse manager and manages our team of nurses. So apologies for that. Then on to Leyland, and what Leyland's going to be talking about, and Leyland's one of our embryologists. Leyland's going to be talking about how embryos develop, and you're going to see some brilliant pictures of how, or videos of how embryos develop, so those earliest stages of life. Then on to Katie, who's our laboratory manager and a very senior embryologist, one of the most senior in the UK, and she's our manager for that team in the embryology area. And what she's going to be talking about is some of the risks that come out from IVF, in particular multiple births. That's the most significant one of all. And it's absolutely vital that we get that incidence down as low as possible. But what Katie's also going to be doing is talking to you about our success rates, in particular for NHS patients, because that's the focus for tonight. Then I'm going to talk to you about research, and then I'm going to go on to how you could become a staff governor if you're interested. So we're going to take you through all of those key elements, but what I'll ask each of the team to do is just to say a few more words about themselves. There's an enormous amount of training that people have to do to get into IVF. Alka's got over 15 years experience within IVF as a consultant. Leyland and the embryologist, they've all got 3 degrees to become a state registered scientist. So it's a really, really complex process, but that's because it's so important that we get it right when we're creating life. But if I can pass on to Alka first, thank you very much indeed.
Thank you, Chris and Namu. Good evening, everybody. My name is Alka Prakash, and I'm one of the consultant gynecologists leading the fertility services at Cambridge IVF and CUH. I don't have the slides in front of me, Namu. Excellent. Thank you very much. So essentially, today's evening is all about fertility and reproductive medicine. And quite often we see people trivializing it and saying, well, it's just a quality of life issue. But actually, it's a public health issue. And that was declared by WHO to be a global public health issue not too long ago. And in fact, the rate of rise of fertility, or rather decline of fertility rates, has been so remarkable that UN is suggesting that these rates are expected to decline to as low as 2.4% by 2030. And what basically that's meaning is that the social demographic is changing. As a snapshot picture in UK, you see about 3.5 million patients, and worldwide, this is 186 million people who have fertility issues. And to put it in a different perspective, the 30, 40-year-olds, so sort of young working class people, it's one of the most common healthcare condition that they report with. And therefore, it becomes a very important medical issue. It's defined as a couple unable to conceive despite having unprotected intercourse for over a year. And that definition may vary slightly based on the woman's age. So, higher the age, the lesser the length of time that we allow them to just continue trying on their own before we intervene. Regarding types of fertility or other causes, that can depend on a wide variety of factors, but just on an eyeball, what we find in our clinics is about 30% of our patients are female factor, another 30% are male factor, and then there is this big 30% that is unexplained. And by unexplained, I mean it doesn't mean that there isn't a reason, but it's more likely that science just hasn't as yet given us the technology to find those reasons. And that is why there's a lot of background research work that you'll hear about later on that's going on to try and reduce this unexplained number and actually label them as a cause. Because once you know what the cause is, you're more likely to be able to treat it. And then there's this 10% combination of factor where there's a combination of male and female factor or other things. A very important demographic trend or social trend that is impacting fertility and the rates of conception is the trend towards late age of conception. And previously it was thought that it was only the female factor that it was impacting, but now we know that it's both sort of the man and the woman, and the late age of conception is impacting the egg and sperm quality. And this, unfortunately, is one area of the human biology that science hasn't been able to overcome, i.e., we are not being able to treat age factor of subfertility very well. So, can I have the next slide, please? And treatment really will depend on what is the cause. So the main participants in fertility is the sperm, the egg, the tube, and the uterus. And that's where we look for our causes for subfertility. Is there any one of these four? And depending on what we find, we treat accordingly. And that may be something as simple as ovulation induction, which involves treatment by tablets that force ovulation from an ovary, or it can be a very complex assisted conception, which is basically encompassing all types of IVF, ICSI, insemination. So, really, our treatment will be dictated by what the cause is. Unfortunately, however, whatever we may do, success rates of IVF are very limited. And despite the best science, the best sort of individualization, success rates are limited to under 50%. And therefore, it's interesting and very emotive when we are talking to couples that it's the only area in medicine where you're probably less likely to succeed than two in after starting a medical treatment. Having said that, it's not a very invasive treatment, but any treatment in medicine comes with risk and complications. And one of the most important risks of fertility treatment is the risk of multiple pregnancy. Now, most of my patients and even the general public turn around to me and say, well, what's the problem? Twins are fine. They're cute. We actually want twins. It completes our family in one go. But that's a perspective of somebody who see healthy children. As doctors, we see twins when they're admitted in our neonatal intensive care for months together, and that leads to a huge amount of issues for not just those children, but for the entire family. So it is a very important risk, though even though it may think you may think it is not that consequential, but it has a huge impact. And then there are other risks like ovarian hyperstimulation syndrome, which basically is you're overdoing something that you should try and avoid. And it's very difficult biologically to control the ovary. So when you're forcing it to do something, it overdoes and produces a lots of estrogen. And nothing in excess is good for us. We all know that. And too much estrogen can just disrupt our salt water balance. And what is perceived as a straightforward, simple treatment can actually lead to significant morbidity and mortality as well. And therefore, individualization of treatment and finding of these better treatment options is really quite imperative. And that is why you'll hear in the next few slides what is being done to improve our diagnostics, our semen test, our sperm selection, and finally, how are we reducing these multiple pregnancy rates? So over to you, Michelle.
Thank you, Alka. My name is Michelle Freer. I'm currently the nurse manager at Cambridge IVF. I've worked for the clinic for 8 years. So I'm going to talk to you about advances in IVF, more specifically diagnostic ultrasound and how we use that. So the first slide, so Ian Donald was an English physician who pioneered diagnostic use of ultrasound in obstetrics, enabling the visual discovery of abnormalities during pregnancy. Together with an engineer called Tom Brown, he developed the world's first contact compound 2D ultrasound scanning machine called the diosonograph. The ultrasound images were lacking in grayscale and static and were created on a cathode ray tube by rocking the transducer slowly over the abdomen. The images, the top images in this slide, basically show an early image of a baby and placenta, and also the early ultrasound scan machines that were used to create this. So that was the very beginning. The race had begun, and over the next 50 years, technological developments such as real-time imaging, colour and power Dopplers, transvaginal sonography, and 3D and 4D imaging occurred. All these developments are now used to enhance the investigation and management of patients in many areas in obs and gynae, such as assessing fetal growth and well-being, screening for fetal anomalies, prediction of conditions such as preeclampsia, preterm birth, and evaluation of pelvic masses. Ultrasound-guided procedures are also now an essential component of IVF treatment. The image in the bottom left of the slide shows a picture of a fetus in utero. Detailed images help the sonographer detect fetal anomalies such as cleft palate. They also help the parents form an early bond with their unborn child. The ultrasound machine in the bottom right of the slide is the Volution E8, like those used at Cambridge IVF. It has high resolution imaging, colour and power Doppler, and 3D and 4D imagery. It's used to help identify causes of female infertility, and it's also used to monitor our patients during their treatment cycles. Next slide, please. So every woman seeking fertility treatment with us will have pelvic ultrasound examination using 2D and 3D images. It's used to closely examine the uterus to help identify whether there is any anomaly that might affect embryo implantation. If you look at the slide, the image on the left the left-hand image shows a normally shaped uterus. The remaining images show 5 different types of uterine anomaly, such as arcuate, bicornuate, and septate uteruses. By having advanced knowledge of this anatomy prior to embryo transfer, it enables the clinician to assess whether implantation is likely to be successful or whether surgery is required or necessary prior to treatment. Ultrasound can also be used during the embryo transfer procedure to help guide the embryo to the optimal position in the uterus. The 2 images to the right show a fibroid and an endometrial polyp. Again, knowledge of these and the position helps the clinician to assess whether they are likely to cause a problem with implantation and the likelihood of a pregnancy developing. In IVF, ultrasound is also used to individualise treatment. Together with blood tests, an individual's medical history and their diagnostic tests such as semen analysis, this is all used to help individualise treatment. Whilst having a pre-treatment scan, the sonographer will also check the antral follicles in the ovaries, and this information is then used to help individualise the dose of medication used to stimulate the ovaries during an IVF cycle. The images on the bottom right clearly show ovaries that have been stimulated. Transvaginal ultrasound is used to accurately measure these follicles as they grow. This information then helps us to assess when a patient is ready for oocyte retrieval. Over to you.
Hi everyone, my name is Elisa Ferraro and I am the andrology service lead at Cambridge IVF. I've been working in the uni for the last 7 years and I'm here tonight to speak to you about male fertility. Male fertility is becoming an issue is becoming more and more of an issue, especially in the last decades. And the scientific community has noticed a drop in the sperm parameter, especially if we compare sperm parameter from 50 years ago. Just some fact, as we all know, a woman is born with a set number of eggs, while men are able to produce sperm throughout their lives. And the process of sperm production is called spermatogenesis, which is a process that lasts between 60 and 70 days. A sperm cell is a very complex cell, and it's the smallest cell in the human body. And if you look at the picture where the sperm is, you can see how complex is the sperm cells. It has 23 chromosomes inside the head, and it can carry the X or the Y chromosome. That means that the sperm cells at the moment of fertilization is the cells that will determine the sex of the future baby. And because of their size and their movement, sperm are very difficult to analyze. This means that it's really important that semen analyses are conducted in a lab with trained scientific team, and the training that our scientists attend is a very complex training process. In the image on the right, you can see image from 6 to 10. They are images about normal shaped sperm. And the images below between 13 and 18, you can see the shape of abnormal sperm. May I have a next slide, please? Thank you. So at Cambridge IVF, we perform around 4,000 semen analyses per year. And these happen in our 3 main laboratories. We have a laboratory at Cambridge IVF in Cambridge, and we have 2 satellite clinics, one in Ipswich and one in Peterborough Hospital. So when performing a semen analysis, we look at different parameters. We look at the volume of the sample, we look at the color, we look at the motility, meaning that we look at how the sperm cells move. We look at the concentration, and this means that we look at how many sperm are in the sample. And we look also at the sperm morphology, which is the shape of the sperm that we discussed in the previous slide. At Cambridge IVF, we also test samples for those men that had a procedure called vasectomy, men who are not willing to have babies or don't want babies anymore. So we test their semen to check if the procedure has worked. We also perform fertility preservation for those patients who are undergoing oncology treatment, these being a surgery, chemotherapy, or radiotherapy. And this is a very successful service that we provide to our community. Every month, we are able to see between 8 to 10 men before undergoing oncology treatment. In some circumstances, we are also able to perform what is called surgical sperm retrieval. This means that for some patients, we need to go straight to the testes to extract the sperm. And we normally suggest our patient that improving their lifestyle, making some changes in their lifestyle could potentially improve their male fertility. And as you can see in the image on the right, you can see all the factors that can potentially have an impact on male fertility. So once again, male fertility is becoming an issue. Male fertility is important as well. Thank you.
That's me next. Thank you, Marie. So whilst Marie gets my slides up, I'll explain to you guys where we come in, the embryologist. So after a gentleman has gone to see Elisa and their team and had their semen diagnostic test performed, the doctors will then come up with a plan or devise a plan for the couple or a patient going in with donor sperm or eggs, devise a plan on how they're going to start the IVF treatment. And then when the time is right, they'll come and see us and we'll collect their eggs, prepare the sperm, and then hopefully create embryos. So you can see on the video on the left. So this basically is a video that shows the first 5 or 6 days of human life in 30 seconds. So you can see the embryos dividing to make 6 cell to 8 cell, many more cells, form a nice tight ball called a morula, and then you can see it making the jump to form an advanced embryo called a blastocyst. Now, if you could please click on the videos on the right, and to start them, and the next 2 below it as well, please. Thank you. So you can see these 3 embryos are from our lab as well, these 3 videos. You see that they both started off from the same sort of time point, same sort of grade, but then as we continue the video on, there's massive differences in their quality. So the top one you can see has formed a nice blastocyst. Other 2 unfortunately haven't made it so. And the next click, please, Namu. Thank you very much. Thank you. You can see for the first 2, the first one was a very good quality blastocyst. Second one, although it was used for treatment, unfortunately it was poor quality, and then the last one unfortunately degenerated. So basically for over a decade, IVF labs have been able to capture these videos of embryo development using a technology called time-lapse incubation. Now, before this technology was in use, embryos were removed out of their optimal conditions of an incubator that did not have a camera in it. What we used to do is we used to carry these dishes that had these embryos developing, take it over to the flow hood where we will do a microscopic evaluation of these embryos in a static snapshot assessment. Now, from the early 2010s, time-lapse incubation was introduced, which allowed the continuous monitoring of embryos in the lab. And this time-lapse incubation machine was essentially an incubator, providing the optimal temperature and gas conditions, but not only was it that, it also had an integrated camera system that captures images of embryos at regular intervals, every 10 to 15 minutes. Then over time, during embryo development, these images would then generate a video footage. Now, thanks to this invaluable technology, embryos can then be monitored in real time and viewed at the end of the culture as a video sequence, covering the entire time of development or while remaining in the stable environment within the incubator. It also allowed us for us embryos to see transient events, so events that we would not be able to see if we took the embryo out at certain time points. So we were able to see all the developmental time points during embryo development. Now, these videos highlight the importance of this technology to not only select good quality embryos, but also it helps us deselect embryos. And this also plays back into Alka's slides. This technology really helps us in terms of selecting the best quality embryos that we can transfer, one embryo to sort of promote a single embryo transfer. And you can see from the videos on the right that although embryos start off at the same sort of, they start the same starting point, unfortunately they may differ towards the end or the end of their the culture. So you may be wondering, how do we create embryos in the lab? So there are 2 main ways we can create embryos in the lab. So that's IVF or ICSI. Now, IVF, I'm sure you guys know already, we add sperm into a dish that contains the eggs, and then the sperm will do their own thing. They'll swim to the eggs and, fingers crossed, fertilize them, just like natural conception. However, in some cases, there may not be enough healthy sperm to fertilize the eggs. In these scenarios, ICSI, which is intracytoplasmic sperm injection, this is a technique that has been around since the early 1990s. This could be used where we will directly inject 1 sperm into an egg. Next slide, please. You can, perfect, starting. So first what we want to do for ICSI is we want to select, a good looking sperm, and then you'll see us slashing the tail, and this slashing, or swiftly moving the needle across the tail, this impairs the sperm's motility and destabilizes the membrane of the sperm, which is really important for fertilization to occur. And then can you click on the other video, please? Thank you. So Elisa mentioned that the sperm is the smallest cell. The egg is the largest cell in the human body, which is incredible. So you can see here we've got the egg held in place by holding pipette. We then got the sperm. We go through the outer shell into the inner, suck up the cytoplasm to break the inner membrane, and then expel the contents of the egg, including the sperm, and then safely, very slowly and gently remove the needle out. Next click, please. Or yes, please, next click. Thank you. So another technique performed in our lab is something called magnetic activated cell sorting, or MACS. This technique is used during sperm preparation to improve sperm quality by removing sperm with damaged or fragmented DNA that's been seen to negatively impact fertility outcomes. So MACS works by adding magnetic beads that adhere to the sperm with DNA damage, because these damaged sperm have special markers on the membrane. The sperm with the magnetic beads attached are then pulled out the solution using a magnet. So go through the red sperm, they're pulled away in this column. And then at the end, basically removes the sperm that is more likely to cause problem in terms of poor embryo development and so on. So allowing us to have good sperm at the end with intact DNA that can now be readily used for ICSI. So in short, MACS is sort of like a cleanup tool for sperm, helping to pick the best ones by removing those that are less likely to succeed due to DNA damage. It gives patients better chance of having a baby with a healthier sperm selection. And again, this will then help us in the end sort of goal of selecting one embryo that has the best chance of achieving implantation and pregnancy, and fingers crossed live birth. Thank you. Over to you.
Hi, I think I'm speaking next. Perfect. Thank you. Thanks, Namu. That's brilliant. So my name's Katie. I'm one of the embryology team, and I've been working at Cambridge IVF since we opened in 2011. And before that, I trained in Newcastle. So I've been doing this since 1997. So too long to think about, really, but here we go. So I'm going to talk a little bit about multiple births, because as Alka has already alluded to, one of the biggest risks in IVF treatment are multiple pregnancies and multiple births. So if we look back 20 years ago, a quarter of all IVF births were multiples. And when I say multiple, I'm generally talking about twins, but we also have seen higher order, so triplets as well. So 1 in 4 IVF births were multiples, and that was 25 years ago. And now we're down nationally to about 6 to 7% of IVF births are multiple. So it's come down dramatically, which is fantastic. But we're still working towards reducing that further. And when we compare that to the general population natural conception, the risk of twins is about 1 to 2%. So we are quite a lot higher than naturally conceived twins. So you'll see on the right how are twins made. If we replace 2 embryos and they both implant, we create non-identical twins. And then on the lower picture, we can implant 1 embryo, replace 1 embryo. And if that embryo splits at the time of implantation, it produces identical twins, so formed from a single fertilized egg. So the top scenario, we can control. We can choose whether to replace 1 or 2 embryos. The lower scenario, we have no control over. It's a natural phenomenon. And both of these types of twins are higher with IVF treatment. So the reason the incidence of twins is higher is because historically it's been fairly common practice to replace 2 or 3 embryos. So when I started out in IVF, it was fairly common, probably 75–80% of transfers were double embryo transfers. Now we're looking more like between 10 and 20% of transfers are double embryo transfers. So over the last 20 years, there's been massive move towards replacing 1 embryo rather than 2. So I'm going to rewind a little bit and try and explain a little bit about the risks of multiple births. So the risks, and we try to explain this to our patients who are considering having double embryo transfer, that there are increased risks of miscarriage, of gestational diabetes, preeclampsia, pregnancy-induced hypertension, and the biggest one really is premature delivery, so babies born before 37 weeks. and along with that comes the reduced birth weight. And I think probably more than 50% of twins are born prematurely, so it is a high risk of preterm delivery. And between 40 and 60% of twins do need intensive neonatal care at birth. So it's a high proportion of twins need that extra care, extended stays in hospital. And there is a small minority of twins that are so severely affected that they will have ongoing health issues and developmental problems such as cerebral palsy. So I think the risk for twins is about 8 in 1,000 compared to about 2 in 1,000 for singletons. And it's not just the risk at birth and the risk to both mum and babies, but we've then got the ongoing problems. So we see increased risks of depression, the impact of families on families, and higher rates of divorce as well in families with twins. And I think, as Alka said originally, when we see a lot of our patients, their biggest concern is getting pregnant, and the biggest risk to them is that not working. And from our side, we want to keep our live birth rates nice and high, but ultimately we're also trying to minimize that risk to the unborn baby. And a lot of these risks are avoidable. So the conundrum we're faced with is, how do we keep our birth rates high, but how do we keep our multiple birth rates low? And that's really about trying to select the population of patients that are going to benefit from a single embryo transfer, and those patients that will actually benefit from having a double embryo transfer. So what has been done and what can we do now? So in 2007, the HFEA, which is the Human Fertilisation and Embryology Authority, our UK regulator, introduced what they called a one at a time campaign. And the aim of the campaign was to try and encourage clinics, health professionals, patients to consider having one top quality embryo replaced at a time. If that cycle was unsuccessful, but we froze embryos from that cycle, so the idea is to create good quality embryos, replace one and freeze the surplus ones. Those embryos can then be warmed and transferred one at a time. So overall, the cumulative rate is lovely and high, but we are keeping that multiple birth risk low. So we've seen over the last 20 years, there's been a massive decline in the number of double embryo transfers. So now, as I said, we're probably looking at between 20-25% of cycles are doubles, the rest are single embryo transfer cycles. And as part of this campaign, they were aiming to teach clinics, to help healthcare professionals, educate patients, and they also set a multiple birth rate for all clinics. Initially it started at 15%, so multiple birth rates had to be kept below that. It was then reduced to 12, and now we are aiming to keep below 10%. So we've definitely seen a change in mindset, and we now actively try and encourage patients to have single embryo transfers where it's appropriate. And I think probably having listened to Leylan, we can see some of the things that have changed over the last 20 years. We've got advanced technology, we've got EmbryoScope, and this helps us select the best quality embryos for transfer. We've actually moved towards extending culture as well. So when I started, it was very typical to do a transfer on day 2, when it was a bit like Hobson's choice. A lot of the embryos were good looking 4-cell embryos. But if we can actually extend that culture to day 5, we can see that over the course of those extra 3 days, the embryos get the chance to develop onto the more advanced stage, the blastocyst. And it's almost like a selection of the strongest. Natural selection, the strongest ones will develop, and the poorer quality ones stop developing. So it helps us select the strongest embryos for transfer. And we've also seen improvements in freezing. So good quality blastocysts can be frozen, so surplus embryos can be carefully stored for future cycles. So we can aim to do a transfer of one good quality embryo. If that cycle is unsuccessful, the patient can come back, and we can aim to warm one embryo and transfer that, and keep going, so actually cumulatively live birth rates remain high. So that conundrum of how do we decide one or two embryos, and it's
actually sorry, Katie, can we go on to the final slide, please?
Yeah, of course. Yeah,
time. Thank you.
Yeah. So when we're talking about outcomes and performance, we're actually looking at measuring live birth outcomes. So the top line actually illustrates our most current live birth outcomes. So these are for our NHS patients, and we're looking, the majority of these will have had a single embryo transfer. And we're seeing lovely, strong live birth rates in our youngest group under 35 years at 56%. 35 to 37, we're seeing 42% live birth rates, and 38 to 39 years, we're seeing live birth rates of 40%, which is absolutely fantastic. And alongside live birth, we're also monitoring, and you'll see the two lower dashboards looking at ongoing pregnancies. So we like to monitor what proportion of our pregnancies are multiple pregnancies, and we tally that with looking at our multiple live birth rates. So when we start to, you'll see the pink dotted line, that is our 10% limit. When we start to approach that, we are looking at what proportion of patients are refusing to have single embryo transfer, and also what proportion of our embryo transfers are double. So you can see that bottom graph, back in 2011, 2012, approximately 60% of our transfers were doubles. And over the course of those 10 years, we've come down to about 20%. So our aim is to effectively try and stabilize successful outcomes by minimizing multiple births. Thank you.
Thank you very much. Okay, if we could go on to my slides, that's brilliant. Thank you very much indeed. So just to summarise very quickly some of the key points you've heard. Firstly, from what Alka was saying, 1 in 7 couples are struggling to conceive. And the best we're getting to is around 50% on success rates, despite all of the advances you've seen there. So one of the biggest things you saw there was the changes in ultrasonography. You saw those initial images where, quite frankly, there's no way I could have told you that was a baby when they were first doing the scans, whereas now you can see how clear it is. Also, if you look at that, over 50% drop in male fertility, when you think, quite frankly, men have just got to produce the sperm, but half the time now we're finding that there's a male factor. And also that Elisa and her team are testing 4,000 men a year, which again gives you some idea of the scale. And the sort of things we don't know, as Leyland was saying, we don't know why some of those blastocysts did not develop. So they stayed as the bad and the ugly. We don't know why yet. It's beyond the limits of science. As Alka was saying, some of these things we just don't know yet. What we do know on time lapse is when we introduced time lapse in Liverpool for NHS patients, our average success rate went up from 30% to 40%, literally just by introducing time lapse. And one of the things that we are noticing is that in the UK, there are these targets, but a lot of patients are going over to other countries, and then they're having multiple embryos put back, and they're coming back with quads or triplets that then are in the NHS for us to look after. And that's partly because the NHS doesn't pay for a lot of IVF, unlike, say, Denmark, where there are 6 cycles paid for. Let's go on to the future and innovation. So you can see the pretty picture there on the right. That's actually from some research we're doing with the University of Birmingham. They're trying to automate that really complex ICSI process, because that robot they've designed can inject an egg to an accuracy of micrometer levels of accuracy, which is beyond the limits of what a human can do. So we need to have innovation, because, quite frankly, if IVF demand keeps on growing, we will not have enough scientists in the UK. It takes 7 to 10 years to train somebody like Leyland, Elisa, and Katie to be able to do that job. We simply don't have enough of those those scientists being trained, and we're going to be training 9 a year by the end of next year. But even with that, we won't have enough scientists in the UK. If we look at other things that are going to be happening, the brilliant work that's been done in the UK on genetics means the UK is going to be having a lead in that area. So when we're able to analyze the whole genome, we can see the mutations that then impact on fertility, and that will enable Alka and her team to start individualizing treatment much more than we would currently do so. So if you look at what's happening at the moment, very often we'll have the first IVF cycle, and that will then help us determine what to do on the second one. But what researchers are working on at the moment is how to make gene analysis accurate enough and cheap enough for it to be part of general IVF. And we're getting very, very close to that point. If we look at the medication, there are always new drugs coming through, but you've got to be incredibly careful with new drugs. Some of you will have heard of thalidomide. That's actually what I first started working on as a research scientist. So I was a reproductive toxicologist looking at what drugs can do to impact on growing embryos, etc. You've got to be very, very careful what you do. If we go on to my next slide, what's going to be happening in terms of the longer term future? There's some really exciting stuff coming through, but it's going to take time for these things to come through. One of the areas is miscarriage. That's an absolute priority because it's so devastating when couples have had a miscarriage, and many couples sadly have recurrent miscarriage. And that's what Alka did one of her doctorates in. So that's a really, really important area. One of the most important things we think could be novel methods for sperm selection. So we've been investing very heavily in our andrology team, because in most ejaculates you get millions of sperm. Choosing the best one could help us improve outcomes. Also, if you look at genetic analysis of sperm, which is what they're doing at the Wellcome Sanger Institute, just south of Cambridge, that's going to be absolutely brilliant in terms of, I think, the longer term for IVF. And again, how we individualize care and choose the best sperm. In the very, very longer term, so we're not talking the next 5 years, we're probably not talking the next 10 years. There could be the work that enables us to develop stem cells into adult cells. We have to do that with incredible care, because when human gametes are being grown through spermatogenesis, as Elisa said, so when we're creating sperm, that spermatogenesis process has a very low rate of mutation. That's not the same in general cells. Okay, so creating gametes from stem cells, we're some way off because we'll have to choose the best sperm. Another one that's going to be ultimately what we're going to be able to do is to edit the human genome before the babies are transferred. Okay, so before we transfer an embryo, we'll be able to edit the genome to add protections. If you look at it, that's already been done. I was out in China at the time when a doctor changed the genome of 2 babies to reduce their likelihood of getting HIV. That was a really stupid thing to do, and he got locked up as a result, because what he was doing was changing something without us knowing what the impact was going to be longer term. So that's on innovation, and there's a brilliant book called Hacking Darwin by Jamie Metzl, if you'd be interested in looking at that. That's on audiobooks, but you can also get the book. Some of it's a bit apocalyptic, quite frankly, because it's talking about what could happen as a result of changing the genome, but it's very, very exciting, and my goodness, he's hit the nail on the head. If I can quickly go on to CUH membership, please. So this is, how do you become a governor, and why would you want to? What it enables you to do is become much more closely involved with that trust and find out more about what's going on and getting the information first. And there's loads of things going on at Adam Brooks, the 2 new hospitals, etc. So it means you can stay informed, it means you can have a voice, it means you can vote for governors. So you can vote for people like me and have somebody who represents your views. And we have patient governors, we have staff governors, so I'm one of the 4 staff governors. If you want to be a patient governor, or one of your family has had treatment, if you live in our catchment, or if you've had treatment, then you may become a member. And all you need to do is to do a Google search for Joins CUH, and you can fill in the application form. It's very, very easy. But if you're going to be looked to become a member, you need to be 16 plus. And as I said, you need to either live in the catchment or have had treatment here. But thank you very much. What we're going to do now is to pass on to questions. So I'm going to try and look on the questions. Can you see the questions, Namu, and start firing them off?
We've only had one question, which Alka has replied to.
Okay, Alka, do you want to cover that question?
We can still say that for other people. So the question is, do we offer TESI and micro-TESI at Cambridge IVF? So for those people who don't know, these are surgical sperm retrieval techniques for male factor subfertility, where we are able to recover sperm directly from the testes surgically. And yes, we do have this service available via our urology team, who have specialist sessions at Cambridge IVF, and jointly with us, we do offer it via the Cambridge IVF.
Okay. Any other questions? Because I was asked to this morning when I was in the diabetes centre by somebody who couldn't be on the presentation for tonight. Okay. So the first one is, why are success rates so low compared to other areas of elective treatment? Alka, would you like to start on that one and then pass on to Katie?
So the most important reason for low success rates is because when you don't know what the problem is, you will not know how to treat it. And that's where there is a lot of stuff which is happening at a molecular biochemical level, or rather genetic level, that we are still trying to figure out. For instance, we see that when we are developing these multiple embryos for a patient, quite a few of them would be genetically abnormal. And therefore, there is this theory and concept that maybe if we start testing embryos for genetic abnormalities, our success rates would rise. But even that hasn't translated into significantly higher success rates, although there are appropriate tests to be done in appropriate circumstances. So it is something that needs further evaluation. There is still a lot of understanding to be gained by research and science as to what are the biochemical markers. So one of the most common things that is under research is, could it be an immunity factor? That means, is the embryo and the uterus not talking to each other appropriately, and therefore implantation of good quality embryos compromised? There's a lot of work being done to switch off this immunity, and you may Google and read about things like natural killer cells and role of steroids and how to suppress the immune system. Um, I would be wary of putting these things onto clinical practice till we have enough research giving us the answers for safety purposes for our patients, because we can't just be mavericks and keep trying. We can't use our patients as human guinea pigs. All these things, all these theories have to be tested in the lab before they can be applied to human clinical patients.
Okay, and Katie.
Yeah, I mean, it's hard. I think the unexplained part of infertility is the most frustrating, because if it's female factor, male factor, quite often we can overcome those. But for a lot of patients, it's unexplained. And we can grow embryos, replace beautiful embryos, and still not achieve pregnancy. And it's that unknown, because we don't know what happens once the embryo is back in the uterus. Why isn't implantation happening? And I think that's the most frustrating thing for a lot of our patients. So there's so many unknowns, and that's why research is so important going forward.
Yeah, I think I'd add to that the work that we're doing with Sanger and others to look at the sperm selection, I think could be very important, because we simply don't know what's going on with that sperm. And one of the other things that one of the scientists at Wellcome Sanger was mentioning is it could be that mitochondria have got something to do with that arresting of development. So when those embryos you saw where they were developing normally, sometimes they stop and we don't know why. And their theory, or one of their theories, is that could be something to do with mitochondria. Now, when you find the cause of something, then we can treat it. But until, as Katie was saying, until we know what it is, we can't do anything about it, because, as Alka was saying, we can't use patients as human guinea pigs. We can't just fire out all these different things and just try them. And if we get it wrong, as I said, there's thalidomide and things like that show you what can go wrong if you get it wrong. Next question. Right, there was a question there about a role of sex education. Could you read that question for us, please, Namu?
Sure, and then we've got one more after that. So this one is, for unexplained infertility, is there a role for sex education, reduce stress?
So can I take that one? So effectively, stress has a huge impact on any type of steroidal pathway in our bodies. That's human biology, and fertility is very closely linked to that. And therefore, the very generic advice is to reduce stress. There is no question about it. Unfortunately, however, stress is not something that you can measure by an objective test and say, well, you have level grade A, B, or C stress, and you have to take this or that to reduce that. So, what our advice to our patients is whatever you require to reduce your stress, do that. And one of the things that certainly patients for fertility tend to try and do is to have this timed intercourse at certain times of the month, which all it does is increase the stress and performance anxiety and does nothing to improve success rates. So it's these type of counseling and general health lifestyle techniques that are very important in terms of education of patients who are trying to conceive. And the box standard is just simple healthy lifestyle, balanced diet, and as stress-free life as is possible. Now we all live in the modern world, and you can't tell somebody, oh, be stress-free. It's not possible. Nobody is stress-free. But to whatever you can do, whether it is sort of changing sort of your sex attitude, or not having this timed intercourse, or jogging or running or exercise, whatever it takes, it will help conception.
Could I just add to that to say that 1 in 15 couples that pay for 3 cycles of IVF, so our most expensive package, they get pregnant between paying for treatment and starting treatment. And what that's showing is that people relax and think, oh, we're going to get pregnant now because we've paid for 3 cycles of IVF. And then they do, not through IVF, but naturally. And so they get a full refund, which is great. Anything else on stress that anybody wants to add? If not, should we go on to the next question? Yeah, okay.
Yeah, okay, there's 2 more. So the first one is from Dr. Delisha. What technologies are used for semen analysis at Cambridge IVF?
That's one for Elisa. There you go, Elisa.
Thank you, Dr. Delisha. Yeah, it's a manual analysis, so this means that we use a microscope. So when a gentleman produces their semen sample, we leave the sample in the incubator for 15 minutes to liquefy, and then we move the sample from the incubator under a safety cabinet, and we start preparing the slides and everything what is needed for the proper analysis, and then we analyze the sample under a microscope.
But in terms of how we treat sperm before we then use it, do you want to answer that one, Katie? Because there's various things that you can do, aren't there?
In terms of using it for treatment itself,
Yeah.
we prepare the sample. We're aiming to get the best possible motile sample for use in treatment, and that's done through centrifugation and potentially swim up procedures. So the idea is that we are left after about an hour of preparation with a nice motile sample. And at that point, we make the decision to either attempt IVF treatment, or depending on parameters, we'll switch to the ICSI, more invasive type treatment.
Brilliant. Okay, we've got some more questions. We probably better rattle through these. I saw one there about BMI. Do you want to say very quickly on that one, Alka?
Yes, so BMI is a very important factor in general conception, and how I explain it to my patients is that any excess fat tissue produces estrogen. That's a source of estrogen, and that will counter whatever treatment we are giving, and therefore this subgroup of women often have much lower success rates. There is the other aspect that, as I explained, there is more to IVF than just the treatment and success rates. It comes with the risk of infection, injury to organs when we are collecting eggs, and that can convert a relatively minor procedure to a major thing. The other aspect is the anesthetic or sedation requirement required for egg collection. Now, yes, we can argue that we do emergency surgery on women with much higher BMI, no question about it, but that's an emergency setting. In an elective setting where you have a healthy patient in front of you, you are trying your best to keep them safe, and therefore NHS has a cutoff of 30 as a BMI, and one of the main reasons for that cutoff is the success rate and to keep the patient safe. Now, you could argue, well, that's just an NHS finance sort of reasoning and finance thinking. But actually, even if you were to go to most private clinics, even they have a cutoff of not beyond 35, at a stretch that to even that patients are often counseled to reduce weight to improve their success. And that is purely to increase their success rates and to improve their safety. So I would totally endorse that BMI cutoff for IVF.
Thank you very much. Namu, what other questions we've got? Because we've only got 2 more minutes, haven't we?
Sure. We've got from Tamara, are you planning to offer PGT a screening? If not, why?
Yes, we are, and that's going to be very important because of all the work I was saying there about testing embryos. My view is that within the next decade, testing embryos for whole gene sequencing, not for a specific genetic condition, but whole gene sequencing will become standard within 10 years because we're getting very, very close to that being affordable and technically possible. Okay, so yes, that's definitely something on the cards. Next one.
Thank you. From Mo, what are the dietary factors in infertility? Is there any evidence that microplastics are involved?
So yes, diet is very important because you need to have a balanced diet to have normal human cellular function, and therefore the general advices about balanced diet. But if you're specifically referring to micronutrients and the non-evidence based sort of
No, he was asking about microplastics. I think microplastic.
So
So the little tiny bits of plastic.
So specifically for microplastics, we have to say that it in my instinct is that it will probably will impact fertility. Whether there is a very substantial evidence as of now from multi-randomized trial, I don't think so, or at least I'm not aware of it. But my gut instinct is that in future we will have that evidence and it will impact things negatively, both in terms of egg quality and sperm quality, as well as sperm egg interaction.
And so I can see Elisa nodding because remember that sperm, we've seen that it's dropped by about 52.6%. Some of that could well be microplastics. Okay, next one.
Yep. This is the final question from Dr. Amani. What is the most challenging case of infertility you have encountered in Cambridge, and how did you approach its management?
Now, this will have to be a 30-second answer, I'm afraid. Okay.
I think it's impossible to answer because at CUH we see highly complex medical patients coming to us for fertility treatment, but we are also very lucky to work in a multidisciplinary setting so that we have all type of specialist help available. So we've got patients with organ transplants who've come to us for fertility treatment. We've had patients with cancer treatment who come to us for treatment. So we do see a lot of complex medically challenging patients. Then we see a lot of patients with different types of mental health issues that we have to help them through counseling, and because remember, it's very difficult to say no to a patient for fertility treatment. It's almost a biological human right for a patient to conceive. So we try our best to make it possible for them. I don't think I can count on just one patient, but most of our patients per se are actually, I won't say patients are challenging, but their situations are challenging.
Thank you very much indeed. One final thing from me, other than to thank all of my presenters, that was absolutely brilliant. Well done, team. Is there's a survey link that Namu's put onto the chat. Please fill in that survey. That would be absolutely fantastic if you can. And we would love it if you click on that, join CUH and become members. But thank you very much, all of you, for attending. That's been lovely.
Thank you so much, everyone.
Thank you.